Good afternoon, everybody. Thank you for coming to my final internship presentation. So I had the privilege to intern for this past semester since January under the mentorship of Dr. Kerath with the Care Lab. And I've been working on some data with the UNC virtual care system. So let's just dive into my project and see what I've done. We're basically exploring what happens behind the screen in a virtual urgent care system. We're trying to explore, I try to explore the factors contributing to finishing the telemedicine encounters. So the agenda for today is I'll start talking about what the project was about, a little bit about how I've done the analysis, and what were our findings and what I've learned from it. So initially, first to introduce the usage of telemedicine, it grew substantially from 2018 and 19. Like when we logically think about it, we're like, oh, COVID probably was the rise when telemedicine started booming a lot, but it was actually a little prior to that since 2018, specifically in urgent care systems. And we know that the urgent care system can improve the overall patient outcomes, and it obviously brings people a little closer to affordable care. And especially in the United States, apparently, the patients spend about 20 minutes to 2 hours in wait time before they even actually get to see their physician. So the disparities of the adoption of technology and broadband in elderly patients in racial groups with like native English speaking people and non-English speaking people, there are so many disparities. Patients who are older adults and non-English speaking adults usually have limited access to the telemedicine. And people living in remote areas with lesser broadband and network usage also. So we try to identify and investigate the factors that that would be able to truthfully deliver the telemedicine care. And we basically saw if the patients were able to complete their telemedicine calls in their urgent care calls. Let me give a little more context. So the study was based on it's a cross-section study, was based on the UNC virtual urgent care system. So what happens is, I'm not sure if y'all have seen our virtual urgent care platform. So there's a web portal. There's a web portal where any patients from about age of 2 years can access to this, irrespective of where they're in the country. They can access to this web portal, and usually what happens, you have something, you register, the patient goes in, or the dependent for them, if they're lesser than 18 or they're disabled, or if they're really older adults, their dependents or the patient themselves can go and register to avail the services of any urgent care services virtually. And once they do that, either they're given the option to have a wait time to see the physician, to be able to talk to the physician, or they can, if the physician is readily available at that point, they can directly go in the call. And if they choose the option of getting the wait time, having the wait time, either they're given the option to be called back by the physician, or they can just wait in the line, in the waiting room. So there are two modes these patients can avail services. It either can be through the phone or through the video. And coming to the study itself, we've had about 22,749 patient encounters from January 2018 to January 2023. That's about like January 1st, 2023. And all the patients about 2 years who received the services were included for this analysis. And a lot of characteristics from their age, from gender, their insurance status, and how much time did they wait for the call, and the date and time of their encounter, how much time was their encounter, how long was their encounter, and what were their complaints, their diagnosis, and if they received the prescription, and also if they would have chosen to avail the service again or probably delayed the service, their feedback was also taken. So we've taken all these variables into consideration when trying to see if the calls, what are the factors that are associated, if the calls were dropped by the patient or completed by the patient. So I used SPSS mainly for the analysis, and I've done some visualizations on Tableau, and right now I'm also doing some GIS analysis on ArcGIS. That's about the tools I've used, but Coming into depth of the analysis, I've divided the data main outcome variable into call status dropped, that is 0, or call status finished would be 1. So and all our predictor variables would be patient and their visit characteristics. That's the age, gender, previous visits, if there are any repeat visits, the insurance status, and the encounter medium they've used. I've recoded all these variables fit for analysis so that they'll be fit for analysis. I've done some descriptives just to see the overall study population characteristics. And so what did we find? Overall, in total of our data, about 91% are completed outcomes. Well, actually 92%, 91.9 is 92%. So I would say that would have probably caused a little bit of bias or in the results overall, but it's a good thing that we had like a large number of completed encounters than the dropped encounters. Our total of insured patients were about 57.5, and female patients were 73% of the entire study population, and the most number of aged patients were 35 to 64, and most patients preferred the medium to be telephone. And these are all the data. And then what did we actually see when we came to the characteristics? Over here, we've seen that the older age, not sure if this is seen here. Sorry. The older age was associated to use mostly the phone, which is also in line with the literature I have found. Most studies also suggest that like older age patients, they usually are not well equipped with using video encounters, so they choose to use telephone and are mostly comfortable using it as well. And then we've also seen that previous virtual care visits, if patients having previous visits usually tend to complete their visits, maybe because they're acclaimed to the environment, so it's easier for them to maneuver through it. Interestingly, we've also found that like patients with no wait time actually drop calls compared to the patients with having a little bit of wait time. This could also be because more than half of these patients with zero wait time have also missed calls. Maybe when the physician tried calling them back, they either, because of the urgency of their situation, either they've gone elsewhere or might have just chosen to not avail care. In conclusion, we've seen that there are so many factors like age and the ease of the medium. The age of the patient might be associated with the medium they choose, and we want to analyze more with why the patients with wait time 0 have been dropping more calls. I think associating this with a little bit more data and network usage and the broadband usage of the patients might actually be able to give a little more perspective on if that's the reason, or is there anything else that need to be researched more. So some limitations of this specific study was it was a single study, so we can't generalize these results to overall urgent care systems in the country. And we weren't able to find the exact reasons for call drops. So to address that, with a little remaining period of my internship until the end of this month, I'm also doing a little bit more further GIS analysis on this, hoping to find a little more fruitful results and probably be able to publish the paper. But without the GIS analysis up until now, we were able to submit the paper to the ICMI Teach conference this July. We're still awaiting the results if the paper has actually been selected or not. That's that. And personal learnings. I didn't put a lot in the slide, but I wanted to talk about it actually. I think personally, I've really learned how I learn through the tools. I initially was trying to use a lot of tools and do a lot of fancy stuff with the data, but I've realized that the quality of the insight generation is more important than how sophisticated of a tool that we actually end up using. But so I've just stuck with SPSS and did a binary logistic model. But right now I'm furthering my skills a little more by incorporating GIS analysis into this. So again, I wanted to thank Dr. Saif Karat for giving me this opportunity to work under him. And I've learned so much from him just in this much time. And thank you, all of you as well, for providing us with this opportunity to have internship as a main deliverable throughout the program. And these are the references. I'm happy to provide the link to my Tableau dashboards or a little bit more into my analysis if anybody wants to see. And I'm open to take any questions as well. Thank you.